Good morning. Welcome to Medicine Grand Rounds. This is really a special Grand Rounds because today is the Gary and Marie Weiner Lectureship. Gary and Marie are two friends that I've made since coming to Madison and have generously provided an annual lectureship with an endowment to provide cardiovascular grand rounds on Thursday, medicine grand rounds on Friday, and just a day of learning and celebration with a visiting professor who this year is Dr. Kim Eagle. So I want to thank Gary and Marie for their support and their really this ongoing legacy that they provided for our department and the Division of Cardiovascular Medicine. Today I have the pleasure of introducing an old friend, Dr. Kim Eagle. He's a native of Montana who attended Oregon State and then went on to Tufts for medical school. He then completed residency and chief residency at Yale New Haven Hospital before undertaking fellowships in cardiology and health services research at Harvard and the Massachusetts General Hospital. He joined the faculty at the MGH and was Associate Director of Clinical Cardiology and Associate Professor of Medicine when in 1994 he was recruited to our neighbor across the lake, the University of Michigan, where he has remained ever since. He's currently the Albion Walter Hewlett Professor of Internal Medicine and Professor of Health Management and Policy, and Director of the Frankel Cardiovascular Center at the University of Michigan Health System. He's an expert in outcomes research focusing on quality, cost-effectiveness, practice guidelines, acute coronary syndromes, and treatment of aortic diseases. He's really has provided outreach and a real change in terms of the state and nation in terms of an effort to fight childhood obesity, and he founded the Project Healthy Schools. And he recognized the need for pacemakers in third world nations and leads the project My Heart, Your Heart, which works with repurposing pacemakers to be provided to individuals who otherwise would not have the opportunity to get a cardiac pacemaker. His research team has led quality improvement initiatives across the state of Michigan in acute MI, heart failure, and coronary interventions. He's published over 600 peer-reviewed articles, 70 chapters, and has edited 8 books. He's served as the NIH Heart, Lung, and Blood Institute's External Advisory Committee member from 2002 to 2006 and has been the study chair for its genetic causes of thoracic aortic conditions, the GenTAC organization, since 2006. He's been awarded recognition by a number of organizations, too many to mention, but I will make note that he has served on the Board of Trustees and is considered a master of the American College of Cardiology. He's also received their Distinguished Teaching Award, and the American Heart Association likewise has honored him with the Linux Society's Clinician Educator Award. He's also a past president of the Association of University Cardiologists and serves as a board member of the World Medical Relief Organization. I first met Kim as an intern, and I doubt he remembers it, but as any house officer who goes through, you have certain times that you recall where, frankly, you felt like you were drowning. And I remember one night on the Baker ward as an intern and had a patient I was convinced would, under my hand, would probably not survive the night. And I needed a cardiology consult, and Kim came in, and we just barely gotten to know each other by then, but he was kind and respectful to this terrified intern, and likewise to the perhaps more terrified patient. And we all got through the night, and I've been fortunate throughout my career to have him as a friend and colleague. So with that, it's my pleasure to introduce Dr. Kim Eagle as he addresses us with the grand rounds entitled Cardiac Risk of Non-Cardiac Surgery, A Piece of My Mind. Welcome, Dr. Eagle.
Thank you very much. It's so kind of you to invite me. I want to thank the Weiners for this honor the chance to come to a place like this. I always learn so much. I have so much respect for this institution and the people that are here, many friends. We live in an academic world of fraternities, sororities that last a lifetime. And it's just a pleasure to be here. So I'm going to talk about a topic that I've been studying for 30 years. My first paper on cardiac risk of non-cardiac surgery was in 1986. So this literally is a piece of my mind, okay? I don't think I have any disclosures that will affect what I say today, but if you know anybody funding research in this area, please send them my way. Also, if you want the slides for this lecture, you're welcome to email me, keagle@umich.edu. I'm happy to send you the slides. So this is the lecture outline that I used to show, estimating risk, cardiac events, testing, therapy, revascularization, and I've changed it. And now it's a rant, a lesson in history, a lesson in research, a confession, and a reflection, okay? So I'm going to bare my soul here. And I think I met a psychologist earlier, so I may need you at the end of the hour. So here's my rant. I get this every day. Clear this patient for surgery. And then I get this. Failure to do so could result in surgery being unnecessarily canceled. And it comes in a sterile fax from somebody I don't know. It drives me nuts. I'm not a clearinghouse. I'm a consultant. I'll help you understand cardiovascular reserve and what could happen, but why transfer the legal issues of this surgery onto me? This drives me crazy. For a while, I fought it, but I had no energy after a while, and I just said, okay, I'll sign the thing. Bring it on. So this is how I think about this topic. Patients bring clinical markers to the preoperative moment. They have a certain level of function in daily life, and they have a surgery-specific issue that may be relevant to the debate. And then we have a branch point. Go to surgery or further evaluation or management might be appropriate. This is the way I think about this topic. These are the conditions that you should try to ascertain in the preoperative moment. What type of surgery? Do they have ischemic heart disease? Remember, their EKG doesn't lie. If they have an old infarct on their EKG, they had an old infarct. And in Framingham, 40% of women don't recall having an MI this past year, even though they show up this year with Q waves and a wall motion change. And 30% of men. Most of them misdiagnosed it. You see it all the time in the spring. Geez, had a good winter, Your EKG is a little funny. Well, I did have this, remember that storm that blew in? I was out doing my snowblower one morning in February, and I got this tremendous muscle pull in my chest, followed by nausea, vomiting, and some pain in my arms. That was some muscle pull, right, Doc? Yeah, it was your heart muscle. So we see this. So the EKG is important. And if they have clearly pathologic Q waves, it's an infarct. Prior heart failure, cerebrovascular disease, patients with diabetes on insulin, and renal dysfunction. These are the 6 that you have to remember. Even a simple person like me can remember the 5 risk factors and the type of surgery. Okay? And this takes you most of the way there. Functional status is so helpful. I work out an hour a day. If I had to go through gallbladder surgery, I would rock through it. I would rock. But somebody who can't do their ADLs or walk 4 blocks, you don't know what's going on there. Do they have poor cardiovascular reserve? What's the cause? So poor functional capacity really is troubling, and we deal with this a lot with our very obese patients where we're really uncertain what their cardiovascular reserve is. This is a study that simply asks the question, can you walk 4 blocks or climb 2 flights of stairs? And if you could, your risk of a cardiac complication was half of a group of subjects that said, no, I can't do that. I have to stop. I want you to remember this slide, and it relates to the relationship between non-cardiac surgery and stroke. This is relatively underappreciated, but stroke within 3 months increases your odds of a perioperative cardiac event a lot, and 3 to 6 months as well. After 12 months, it reaches unity. So recent stroke is very important. This came up in my clinic last week. Somebody had a stroke in November. They wanted their knee replacement. I said, you know what? No, let's wait. We want to wait at least 6 months, and I'd prefer to wait a year because there's some relationship between the stroke and cardiovascular function, and you see it all the time. The patients describe enormous fatigue after a stroke. So there's something going on, some connection we have yet to understand. When we look at the type of surgery, sort of aortic surgery kind of tops the list because it's often very stressful, right? Cross-clamp the aorta, it's a big whack. But non-carotid peripheral vascular is also very important, okay? Major thoracic, major abdominal, these are going to be the 4 that I want you to think about in a higher stress capacity. And of course, this one, many of these patients have concomitant coronary disease. They have bad atherosclerosis. And it's not the surgery that's so dangerous, it's the fact that they also have atherosclerosis in other places. These types of surgery generally do well. The European guidelines have divided this into low risk, less than 1% cardiovascular events, high, or more than 5, and intermediate. And this slide, I think, illustrates, at least in the Medicare population, the notion that peripheral vascular surgery is every bit as dangerous as aortic surgery. Okay? So about 5% mortality with peripheral vascular surgery. This also illustrates the gradient of risk depending on the volume of aortic operations your surgeon does. So if I have a leaking aneurysm in your emergency department, somebody comes to see me, my first question is going to be, how many did you do last year? And if they're pretty young and they did 15, I'll talk to them about maybe sending the person with the white hair or no hair. I like the no hair ones as well. Look at this. This is a 1-year snapshot of the risk of death from total knee replacement in the UK. It's way under 0.5%. So if you find yourself in the preoperative moment thinking about cardiac testing to lower risk, with that, what are we doing? Right? I mean, that's craziness. We do knee surgery very safely in the world, at least in Madison. And the notion that you're going to screen a heart for something that has a risk this low, really you want to think twice about that. And this shows you the basically Medicare data, overall death rates for a period of 9-10 years, 1.7%, non-fatal MI less than 1%. So we do really well these days with getting patients through surgery from all kinds of things. Obviously, if you have a bunch of risk factors, it's higher. The type of surgery matters. I just told you that. And if you look at this slide, if you have 4 markers, okay, stroke, angina, diabetes, and renal insufficiency, well, guess what? Even having bowel surgery is risky business. Walking across the street is risky business. But lower risk patients having low risk surgery don't need screening. They do well. They do well. So here's the simple algorithm again. I love simple. Clinical markers, functional status, type of surgery. Here's your 5 clinical markers. Their relative risks are 2 to 3. 2.4, about 2. Diabetes, 3. Renal, 3. CVA, 2 to 3. Functional status, about 2. And the type of surgery, relative risk of about 3. For me, this is the simple way to think about the preoperative risk. If you want to get more complicated, you can go online and use this risk calculator. It comes to us from the National Surgery Quality Improvement Program. It takes about 5 minutes. Some of my Michigan engineers, they want to know their risk in percentages. I say, okay, let's do this exercise, and I'll give you your exact percentage. Of course, then they'll say, well, where did the data come from? Well, it's from a few 100,000 people gathered in the United States. Well, are they from Ann Arbor? Well, some of them are from Ann Arbor. Anyway, it's endless. So these are the questions then you should ask when you're thinking about testing. Will the results change care? Have they been tested recently? If they've had a good cardiovascular evaluation in the last few years, they're doing fine. EKG stable, no symptoms. They don't need to be tested again. What are you thinking about? Is it coronary disease, LV dysfunction, valve disease? And can they exercise? If you ask the question, what predicts death on a stress test? What predicts future death? It's not ischemia, and it's not EKG changes. It's how long you walk. That is the predictor of death. So if they have great functional capacity, they're going to rock through most operations. What is the most important test before non-cardiac surgery? A great history and physical. The second most important test is another history and physical. Because in that moment, you're going to find new or unstable coronary syndromes, poorly treated or new heart failure, symptomatic arrhythmias, or severe valvular disease. These are the things you want to find. You don't find them with a chest x-ray. Okay? So if we think about valve disease, symptomatic valve disease, we prefer to deal with before non-cardiac surgery because it does increase your risk, especially stenotic disease. Aortic valve stenosis, that's symptomatic. About 10% of those patients will pass in 30 days. So we'd rather deal with that pre-op. How do we know this? These are patients who had symptomatic aortic stenosis and refused to have their valve fixed before their hip or their gallbladder or a lung cancer. Asymptomatic valve stenosis does pretty well. Now we try to make sure they don't have a low preload because their cardiac output and blood pressure is very dependent on preload. You never tell an anesthesiologist what to do, but occasionally you'll say things like, keeping the volume up in this heart helps them have a good blood pressure. Okay? Just saying. Mitral stenosis also doesn't do well perioperatively if it's symptomatic, and you'll see these patients in the recovery room with AFib and pulmonary edema. And you listen to their heart, you can't hear their diastolic murmur, but their first heart sound breaks your eardrums because it's so loud. A loud first heart sound is the footprint of severe mitral stenosis. So this is a data from patients with aortic valve stenosis. 9% if they're symptomatic, 3% if they're asymptomatic. They generally can get through in good places like yours and mine. Mitral and aortic valve regurgitation generally do okay through non-cardiac surgery, but I want you to remember this one. If they have aortic valve insufficiency and they're having a thoracic or abdominal aneurysm, cross-clamping the aorta puts tremendous afterload on their aortic valve and they flood their left ventricle. And they can be in pulmonary edema early in the operation. So here's another time where you're sort of saying to the surgeon, you know, this is one of those cases where a stent graft feels really good to me. And cross-clamping the aorta could be an interesting roller coaster for you. You're not telling them what to do, but you're preparing them for the right thing, right? Okay. And mitral regurgitation, generally, if it's not severe, these patients do well. 30-day mortality, pretty large study, was about 1.7%. So most of these are going to be fine. Now, heart failure. The key with heart failure in the past is understand what it was. Okay? Cardiologists need to get real. I mean, HFpEF, HFrEF, and HOCM are hard to remember for me. This is heart failure with preserved ejection fraction. This is heart failure with reduced ejection fraction, and this is obstructive cardiomyopathy. We ought to come up with some better acronyms, don't you think? HFpEF? Oh my God. Why does this matter? If they have a reduced ejection fraction and they're in trouble, you might diurese them and give them, say, digitalis. But if their heart failure is from obstructive cardiomyopathy, when you diurese them, they get worse. Because in a shrunken ventricle, the degree of obstruction gets worse. And then if you flog them with an inotrope, you really make them worse. So prior heart failure needs to be understood, especially before big operations. And it's worth delaying the operation until you know, okay, you said you had heart failure, you got admitted 10 years ago. We got to figure what that was. We got to know what caused your heart failure. Often you can figure it out from your history and physical, but not always. So remember, obviously, the other one is HFrEF. You don't tell an anesthesiologist what kind of anesthesia to give. Okay, Kim Eagle's rule number 1. However, in a patient with a terrible ejection fraction, you might say something like, you know, all general anesthetics, from what I've read, are negative inotropes. And so Mrs. Smith has an EF of 13%. And I don't know how she'll handle anything that reduces her inotrope. So regional anesthesia for her spine surgery has some value, perhaps, right? You never tell them what to do. But you can talk about physiology. I'm not going to spend a lot of time on bridging except to say we're doing too much bridging with anticoagulants. Just bridge the high-risk people. Recent stroke, very high CHA2DS2-VASc, dramatic heart with AFib, mechanical heart valve, particularly in the mitral position, recent stroke, of course, and recent venous thromboembolism. Just remember those. Most of the rest, bridging probably increases bleeding. We're talking about bridging with Lovenox, right? Probably increases the bleeding and doesn't reduce thrombosis risk much at all. So don't do it. We've been doing way too much. And the way you deal with these, if they have low thrombotic risk and a good renal function, hold the drug for 2 to 4 days. You don't have to use low molecular weight heparin. And if they have intermediate to high, you just hold it for a day or two. That's just a couple of things to remember with bridging. Now, when you're worried about coronary disease, we have various tests to try to find it preoperatively. And this slide is a study looking at the sensitivity of stress perfusion imaging, or echo, to find patients who are going to have a perioperative MI or cardiac death. And I want you to remember that it's only about 85%. So we miss 1 out of 6 with these tests. And if you look at the positive predictive value, this is a summary of studies done over a period of years before vascular surgery. If you have ischemia on a preoperative nuclear stress test, the likelihood of MI or death is 1 out of 8. It's not like it's 50%. 1 out of 8. It's not like you said, oh, you're going to die. It's not high. And for stress echo, it's 20%. So these operating characteristics really have to make you think about preoperative stress testing. If you're thinking about which test, if they can exercise, do an exercise test, because that gives you an ischemic threshold, right? If they go 12 minutes, reach 14 METs before they get ischemia, they're going to roll through most surgery. If you're trying to quantify muscle at risk, then nuclear is probably a little better. If you're looking also at valve disease, echo is better. False positives, echo probably less likely to give you a false positive. Because half the wall of the heart has to get ischemic before the wall really changes with ischemia. And in nuclear, of course, you can find subendocardial ischemia. If you take 200 Wisconsin medical students and do nuclear stress testing on them, 10 to 15 of them are going to have an apical defect. There doesn't seem to be as much perfusion in the apex. Well, why is that? Well, the apex is thinner than the free wall. Of course there's less perfusion. It's thinner. So we were dealing with false positive apical defects forever. Now with the modern technique of attenuating that artifact, we don't do it so much. The role of CT and MR is continuing to evolve. We're not sure. If you're worried about left ventricular function as well, then either one is good. So what about biomarkers? Preoperative elevation of natriuretic peptide, preoperative elevation this is for 30-day, this is for 180-day. Looks interesting, but here's my question. So what? What am I going to do about that? Give them a little dose of Lasix before their surgery? Well, then if they bleed, I'll be sure to knock off their kidneys. I have no idea what to do with these biomarkers perioperatively, but what I definitely don't want to do is chase a biomarker with no therapeutic imperative that's going to follow the test. And right now, I have no idea what to do. And get ready for high-sensitivity troponin. Because when you walk a mile, you may leak a little bit. Okay? What about CT? Now, we know if you've got lots of obstruction, you have higher risk. These are calcium scores, CTA. But again, I don't know what to do about it. Not sure. So I guess I wouldn't do it. So let's move on to my lesson in history. Any of you remember Reverend Bayes? Oh, thank God. So the Reverend Bayes was a reverend by day and a mathematician at night. He wrote math in his kitchen. Cool dude. He had an idea. He said, you know, the likelihood of something happening in a population like this is anchored by the overall likelihood, that's the pretest probability, then modified by a test result. If you only take the test result and don't anchor it in the population first, funny things happen when you use tests. Let me give you an example. Here's a study we did of about 1,100 patients having AAA surgery. Big surgery, right? They were seen by a cardiologist who divided them into low, moderate, and high risk based on clinical markers. At the time, these were the EAGLE markers that have given way to the revised cardiac risk index. Here's a low-risk group. Their overall event rate was 3%, moderate risk 8%, high risk 18%. These people have 3 or 4 markers. Now, they all had a stress test. And the stress test was independently reviewed by an imaging person who said, it looks good, or there's some ischemia, or there's trouble. Looks like a lot of ischemia. So in this group, the low-risk group, the stress test, low-risk stress test, their event rate was 3%. If they had some ischemia, the event rate was, it was 3%. There were 30 that had very ugly tests. Their event rate was 0%. So you're saying, well, obviously this test doesn't work. And then Reverend Bayes would slap you upside the head and say, no, I told you low risk was low risk. You didn't need the test. In fact, it might lead you down a path to do things that are unnecessary. What were you thinking? Here's Dr. Page's Friday afternoon consult, right? He gets in his car, and a vascular surgeon pages him and said, geez, Dr. Page, I just wanted you to know that we're operating on one of your patients tomorrow. Oh, okay. Usually goes something like this. Her name is Hope. We're doing a little fem-pop bypass. Hope has had a few issues. I don't know if you remember her, but she's had some heart failure and diabetes. She's had a couple of MIs. When she brushes her teeth, she gets some chest tightness. But we did a nuclear stress test, and it looked fine. Right? So you know Hope is high risk, right? She's here. So she starts with an event rate of 18%, MI or death. And if her stress test looks good, it's still high risk, 12%. If it looks bad, it's only 24%. Didn't really help that much. She's high risk. 1 out of 10, 1 out of 5, risk of death, MI, that's high risk. Didn't need the test, really. So in this particular study, the sweet spot where the diagnostic test worked was when the pretest probability was moderate, where the event rate was 8%, but if the test was normal, it dropped to 3%, and if it was very abnormal, it went up 6-fold. Now there you're talking about a splay where you might say, you know what, at 3% we'll proceed. At 19%, maybe I'm going to watch this 5.4 centimeter aneurysm. Or if they're having peripheral arterial symptoms, sometimes when I start talking to the patient about a cath, they'll get up and they say, it's feeling better. I think something's occurring here. Doc, my claudication seems a lot better now that we talked about maybe a heart cath. So this is Reverend Bayes' theory in action. the Society for Vascular Medicine said, avoid cardiovascular testing for patients undergoing low-risk surgery. We've got to stop doing this. It hasn't helped. It's driven up costs. It hasn't helped. Should we get a preoperative consult for that? Eye dentistry, I call it. Very lucrative. The number of pre-op consults for eye dentistry is on the rise in our nation. Cardiologists are being called to comment on the risk of eye dentistry. It's crazy. Patients having stress testing before low-risk surgery, well, it's gotten better. The VA is lower than Medicare patients for low-risk surgery, but I would say even here, 4.5% for shoulder surgery, it's low risk. We're doing too much. What causes cardiac events anyway? I think it's due to catechol surges, a prothrombotic environment, blood loss, volume shifts, coronary plaque destabilization, and fixed coronary disease. How many of these does stress testing find? 1. And if you take a person who has moderate asymptomatic coronary disease and they get septic or they bleed badly and have a postoperative non-ST elevation MI, there was no way to predict that. You weren't going to prevent that. Catechol surges happen right away when we do induction. Epi goes up, norepinephrine goes up and stays up after aortic surgery. This probably drives the sympathetic nervous system and prothrombosis, both which are playing a role. And interestingly, the patients who die of fatal post-op MI have bad disease, typically. This is a study we did of 42 patients who had fatal post-op MI who had good coronary anatomy defined by pathology. 20% had left main disease. Most of the rest had 3-vessel disease. And most of the rest had 2-vessel involving the proximal LAD. These are both women, had postoperative anterior MI after hysterectomy. Today we'd call these Takotsubo cardiomyopathy. This kid, young guy, had a gallbladder, ruptured about a 40% right coronary plaque, infarcted his right ventricle. Nothing to do. I remember I had a Stanford cardiology fellow page me one afternoon on a Friday, always on a Friday. And he said, Dr. Eagle, I just wanted you to know that your perioperative algorithms don't work. I said, well, that's too bad. I've been studying this a long time. Tell me about the patient. Well, the guy was 44, and he had a fatal postoperative MI. I said, well, what did the pathology show? Well, he had about a 30% left main, and he ruptured it. He infarcted his whole heart, Dr. Eagle. Your algorithms don't work. And I said, well, I don't know how to find vulnerable 30% plaques in young people. I just don't know. And I doubt that trying to do that routinely is going to be cost-effective or effective for that matter. And the truth is, some of these are going to happen no matter what we try to do. So what about therapies? Talk about beta blockers, statins, aspirin, clonidine, and hemodynamic monitoring. The beta blocker story got launched by Dennis Mangano, studying predominantly vets at San Francisco, showing that beta blocker compared to placebo, most of these patients had known coronary disease, lowered in-hospital ischemia, and lowered 6-month MI death. This got the ball rolling for beta blockers. And then Don Poldermans did the decrease study. Elective aortic surgery. You had to have clinical markers of risk. You had to have ischemia on your stress echo. And then you got randomized to beta blocker or placebo. And in this study, you definitely wanted the beta blocker, because the difference in 28 days of MI or death was an 85% risk reduction. And I can remember 10, 15 years ago when I showed this slide saying, sometimes you see studies and they're almost too good to believe. He showed that if you went to the OR with a heart rate less than 65, your rate was really a lot lower. Okay? keep this in mind because it's going to lead to an important trial. Osler said, I always like to use a new drug before its effectiveness wears off. And here's the beta blocker story. Lindenauer showed that the mortality reduction of beta blockers in Medicare patients with coronary disease having non-cardiac surgery was nowhere near 85%. It was about 15%. And then we had this study where Lindenauer showed, you know, if you just look at diabetics, if you treated them all with beta blockers, you treat 209 to cause a death. And if you just treated ischemic heart disease, you treat 408 to cause a death. Oh, that's the number needed to harm. Not until you got a score of 3 or 4 did you get a number needed to treat with benefit, where you say, yeah, I can see it. The beta blocker might make sense. So Lindenauer was the first to show us the potential dark side of beta blockers in the preoperative moment. And this was another study from the VA, I believe, showing similarly that it's really 3 or 4 markers of risk. Think about that. Diabetes, heart failure, ischemic heart disease. Oh, well, gosh, probably should have been on a beta blocker anyway for either the heart failure or the ischemic heart disease. And this is just more of the same. You got to get to here before beta blockers appear to have benefit. One of the first duties of physician is to educate the masses not to take medicine. And Osler again, I love William Osler. And so here's the diabetes trial, randomized, non-coronary disease diabetics randomized to beta blockers or not, no benefit. Do not consider diabetes a coronary equivalent in the preoperative moment. They don't benefit from beta blockers. And they got a pretty good dose, right? 50 milligrams the night before and 100 milligrams the morning of. I don't know about you, but I never start people on 100 milligrams of atenolol. Take a beta blocker version and give them 100 milligrams of atenolol? Wow, that seems like a lot. And it was a lot. So here's POISE. The POISE investigators, seeing the Polderman's article, said, we are going to beta block these patients down. So they gave them 100 of toprol the night before and the morning of. And look what happened. 8,000 patients. The combined endpoint, cardiovascular death, MI cardiac arrest, it worked. Toprol lowered risk. Thankfully, they had a secondary endpoint. It's called counting the bodies. Oh, no. Mortality went up. People died. About 60 people died. Why? Well, they had strokes and shock. So if you take a patient who's stable, give them 100 milligrams of toprol, and they bleed or get septic, they need heart rate and inotrope to get them through a very significant struggle. And if you block that, you can kill them. This is the dark side of the beta blocker story. And it ain't pretty. The POISE investigators called me about their protocol, and I said, you're using way too much medication. Then they said, would you like to join? I said, I'd never could get through our IRB. They'd say they're using way too much medication. It's crazy. It was crazy. So I'm going to go by this. So who benefits? If you look at the beta blocker story, this group, heart failure and recent MI. Oh, well, duh. Systolic heart failure should be on beta blockers. And we know that patients after MI benefit from a beta blocker for 3 years. So yeah, okay, that's who I want to treat. Diabetics, forget about it. Hypertension, I don't know. I'm not sure I would treat every hypertensive with beta blockers if they're having a big operation. If they're on a beta blocker, don't stop it, because if they're anemic and they're having hip surgery, in this study there was a huge rebound. So if you stop a beta blocker suddenly, 2 or 3 days later they're hypertensive tachycardic. That's not a good sign. So if they're on a beta blocker for a reason that's justifiable, blood pressure, heart rate okay, just leave them on it. If their heart rate's a little low and their blood pressure's a little low, I would cut the beta blocker in half, frankly. I don't want their cardiovascular nervous system to be paralyzed if they need that recovery perioperatively. And I think we've talked about this pretty well. The current beta blockers that are preferred by the European guidelines are atenolol and bisoprolol because they're the ones that have been studied. Avoid high doses, and you'd much prefer to titrate for a few weeks and do not lower that blood pressure too low and do not lower the heart rate too low. Okay? You'd like to take the edge off the peaks, but don't put them in a position of jeopardy. Well, what about the statins? Here's a study of patients having vascular surgery suggesting that statins lower perioperative risk. Well, that makes sense because they should have been on statins already. And we know if you have vascular disease, statins reduce your risk of MI or death by about 35%. Why wouldn't it work perioperatively? It does. Lindenauer showed that the benefit is probably about 35%. Oh, that's the same as all of the secondary prevention trials, 35%. What did I do? Was that me? I'm a non-interventional cardiologist. There's no way I can manipulate a catheter in 3D. Oh, power, Clint. Thank you. Power. So, here's the data on statins and all-cause mortality. It's about 35%. So then came another Polderman's paper. Fluvastatin is a very weak statin. He published this paper in New England Journal showing a 50% risk reduction from fluvastatin. Holy cow. That's incredible. And then he had a combined study where if you use bisoprolol and fluvastatin together, you lower risk 65%. Holy cow. And some of the investigators in Europe, remembering the first decrease trial, said, you know what? These numbers are too good to believe. And subsequently, Dr. Polderman's was reviewed by the University of Erasmus, and they found negligence in his studies. Unbelievable. They didn't review this one, the first one, because it was too old. All of the rest, fictitious method of establishing outcome, no source data. The events actually didn't match the records. Oh, we falsified the profile, or 97% of the patients didn't actually have the stress echo. It was made up. I have never been in a field where fraud so affected what we did. I was on a national surgical quality forum that was considering recommending beta blockers for every patient in America having any kind of non-cardiac surgery. And along with an anesthesiologist from Penn, we argued vehemently that based on a single small trial, we should not make such a sweeping recommendation. And I am very glad we did. This is, for the young people here, this is the dark side of science. And for the mentors, we have to see the data. We have to see the data. Statins do lower risk, but it's about 35%. It's not 50%. So who should be on a statin? Those who are already on it, and certainly patients having vascular surgery. I tend to put them on it. They recommend waiting 2 weeks. I give it the night before. I think statins lower risk. What about aspirin? We get this all the time. The POISE investigators studied aspirin, and there's no benefit on mortality of giving a little aspirin, 100 milligrams. And there is more major bleeding. Oh, yeah. People bleed on aspirin. So aspirin doesn't work to lower risk. We thought clonidine, because it affects the sympathetic nervous system, might lower risk. That was studied, 10,000 patients, absolutely no benefit at all. But there is some, oh yeah, hypotension and bradycardia. I don't think so. The streets are littered with things that haven't worked to lower perioperative risk. beta blockers, clonidine, aspirin. What about using cardiac output guided treatment for patients having really nasty gastrointestinal surgery? Wouldn't it be great to have a Swan Gans in so I can titrate Mrs. Jones' wedge pressure perfectly? This is a nice trial, big trial. No effect on mortality at all. Well, there's I don't know, is that a trend? I don't know. It's in the wrong direction. Zero benefit of Swan Gans catheters. Don't tell anesthesiologists to put in PA lines. There's no data that they lower risk. Very rarely, maybe a bad aortic stenosis situation or severe hypertrophic cardiomyopathy where it's going to be like a big thoracoabdominal. I may say something like knowing preload for 24 hours may be useful here if they get hypotensive. That's about it. That's just about it. What about prior revascularization? Okay, now's my confession. I was pretty convinced for a long time that if you found fixed coronary disease preoperatively before big surgery and you fixed it, you would lower risk. I was wrong. Let me just get it out there. I feel a lot better now. Here's a study by Eagle et al. In which he showed that in the CAS registry, if you had non-cardiac surgery and you'd had prior bypass surgery, your mortality dropped in half and your MI rate dropped by 2/3. Wow, bypass surgery really worked. One small caveat, you had to survive the bypass surgery. Oh yeah, to get the long-term benefit. Non-randomized, right? So what about immediate revascularization? I love the CARP trial. Any trial named after a fish is something I'm going to love. Predominantly veterans with stable ischemic heart disease got screened, and the study group was 510 patients with known coronary disease who were randomized to medical therapy or the best revascularization strategy you could come up with at your hospital. And the patients were typical veterans, 65, lots of heart disease and diabetes. LDLs were being managed for the most part. A third had triple vessel disease. So you think, well, revascularization of those might help. And the typical reasons for surgery. Most of them were on tolerable doses of beta blockers, and a number of them were on statins. No benefit early, no benefit late. Have courage. Stable coronary artery disease does pretty well perioperatively, even having vascular surgery. Every bit as good as good medical therapy compared to surgery or PCI. The left main group, if you could find them, you'd love to find them, but is it worth doing a CAT scan on every one of these? It's a small cohort. And are we choosing wisely today? If we look at the NCDR registry, 60% of the coronary angiograms before non-cardiac surgery in our country are being done in asymptomatic people. We're still not choosing widely. It reminds me of what Upton Sinclair said. It's hard to get a man to understand something when his salary depends upon him not understanding it. And we've built a lot of auditoriums and cardiovascular centers on the backs of coronary revascularization. We're having a hard time unlearning the financial benefit of that. It's interesting. If they've had a balloon angioplasty, you want to wait 2 weeks before non-cardiac surgery. If they have a bare metal stent, you'd like to wait at least 6 weeks, preferably 3 months. And if they had a drug-eluting stent, currently we say 12 months. This is in the US guideline. I think it's old news. Okay? The data from the Cleveland Clinic shows that the likelihood of stent thrombosis is under 2% by 6 months, and it never goes to zero. And recent data is like this. New drug-eluting stents, by 6 months, the stent thrombosis risk, which is about 0.7%, has pretty much flattened out. So if Muhammad wants to have a knee operation at our place, and he's 6 months out from a new drug-eluting stent, he said, listen, I want to do this so I can play golf, assuming the weather will change someday. I'll let him have it. We'll go ahead. And if you look at the risk of events after non-cardiac surgery in patients who've had a stent, it doesn't matter if you stop the antiplatelets, and it doesn't matter what the type of stent was, and if the stent was placed more than 6 months ago, it doesn't matter. It's all about non-elective emergent surgery, recent MI, or the risk index. So if they've had 6 months on dual antiplatelets and they're fine, I say it's very low risk. Okay? I'm not going to go in the interest of time. Okay. So routine coronary revascularization before stable, don't do it. So who needs a coronary angiogram? Same reason as in your practice. Uncontrolled symptoms. Uncontrolled symptoms. Occasionally, a patient whose invasive or non-invasive studies suggest massive ischemia facing a huge operation, then occasionally we'll do it, but usually not. Okay, I'm going to go through this in the interest of time. If you ask the question, who should be screened post-op? Please don't just measure troponins on everybody. Reverend Bays will have a fit. We have fellows chasing troponins in every hallway of our hospital. How many people, after running a marathon, leak their troponins? 10 to 20%. They were a little short of breath. Did they have an MI? Probably not. Troponin does not equal MI. So don't measure troponins unless you have a reason. If it's a high-risk patient with prior coronary disease, get EKGs for 3 days. If they have a symptom or VT or a low blood pressure, fine, measure troponins, but don't chase it. We've done too much of this. So I hope I've convinced you that the foundation of coronary management in these patients is the same as in our practice. And there is the point that sometimes in your history and physical, you find disease for the first time. So here's the less is more. When I came to Michigan in 1994, we screened everybody having a AAA. Hey, they got stress tests, a lot of them got cath, and we revascularized a quarter. We had an industry going, man. And Eagle comes and he wrote the guidelines and says, we're not going to do this anymore. We're going to use the guidelines. And we stopped doing so much testing, a lot less angiography, and revascularization went way down. And interestingly, if you look at what happened with events, even a small number of AAAs, there's a trend toward lower risk. Here's the thought. What would be a perfect human laboratory for studying myocardial infarction? Take a patient with a stable lesion, blow it up with a balloon, put in a foreign body, bleed the patient, give them a few liters of ringers of lactate, and give them some pain. And let's see if they clot that sucker. That's what we were doing. This is my confession. I helped put this field on the map. I'm trying to pull back now. So prediction is very difficult, especially about the future. Nobel Prize, this one. He got a Nobel Prize. Vice President Quayle, the future will be better tomorrow. I think so. I don't know. I'll see. I'll call you tomorrow. Here's one. Trip on Air Force One, $1 million. New suit, $6,000. The weatherproof jacket, $500 for the patch. A vest, $6,000. But your commander-in-chief, looking at his troops with the lens caps on, that is priceless. Don't put the lens caps on. This happens all the time in perioperative medicine. Suddenly you're talking about a stress test for a knee operation that's low risk in a low-risk patient. It's crazy. There's no benefit. It just drives cost, and sometimes you hurt people. So get rid of the lens caps. Oser said medicine is an art of uncertainty and a science of probability. That's really the preoperative stuff that you have to do. A great doctor is thinking about risk and benefit. And when you do it the right way, it can be relatively efficient and very, very good. I like to acknowledge people that are important. I would never be here were it not for a whole host of mentors. I usually try to acknowledge 3 of them, or 4 of them. Larry Cohen, when I was a medical student. Roman DeSanctis, who was really my medical father. George Thibault got me involved in outcomes research. Val Fuster, taught me to think global. My parents, my father passed a few years ago, but they taught me the value of hard work and honesty. The Weiners might be interested in this dude. I was his fishing guide. And when I was in college, he's a very wealthy man. He decided to invest in my career. He asked my parents if he could help pay for college. And then he paid for medical school. I am certain if he hadn't invested in my life, I would not be on this stage today. Just like I wouldn't be if the Weiners hadn't given this lectureship. My son's terrific. My wife tolerates my travel and everything else wrong about me. But really, it's about the colleagues and the students and the residents. You know, these are the people that buoy me up every day. I come to a place that I love, just like you do. Terrific people striving for excellence in a collaborative, compassionate way. It's a wonderful thing to be in, and I'm thankful. And thanks for coming today.
Thank you very much, Kim. We've got time for just a couple quick questions and quick answers. I'll ask you to call on the audience and please repeat the question.
Yes, sir.
So, Ethnic Falls was the former chief president in this program. Do we need more studies like that? He only did it in men and only did it with one kind of surgery. Are we still doing revascularization for the other surgeries, or did this kind of disprove the whole concept and stop us from doing it?
So Ed McFalls helped lead the CARP trial, which was predominantly in men. It's a very good question. So far, I think that generally the audience is convinced that in stable ischemic heart disease, revascularization does not improve survival unless they have left main disease or severe triple vessel with proximal LAD disease. And we're not yet ready to say we should search for those routinely in the preoperative moment. The ischemia trial is ongoing, which is a very large study looking at patients with stable ischemic heart disease who have a lot of ischemia on stress testing. That will perhaps help us. It's not in the preoperative group, but it may inform us that if there's a small fraction of patients who we should consider this. But for the moment, no. We shouldn't be doing it. Yes, ma'am. You know, I don't know if that's true. I've read the reports. I wrote an editorial. Dr. Poldermans is not real happy with me. We shared a number of podiums debating this kind of topic, but he went way out there. And his colleagues were not aware. The current president of ESC has written 100 papers with Don Poldermans. He was unaware. And, you know, we do see this from time to time, and it's a real tragedy. I would like to think that the American system prevents this, but you and I have seen enough stuff in the newspapers to know it doesn't. Wasn't there just a recent report from a professor, I think, at Ohio State, who is in the news for something related? I'm not disparaging Ohio State. I love the rivalry. And this could happen at Michigan for sure, but it just recalls how vigilant we need to be with our methodology and the veracity of our study, because it can hurt people. Those 60 deaths in the POISE trial are because of fraud. That would never have happened if those studies had been right.
So, Kim, we're going to have to end. I want to thank you for an excellent Grand Rounds and for serving as this year's Weiner Visiting Professor.
Thank you.